Okay, in the other set, there's a big, wide osteotome, a 1.5 inch or something, in one of the sets. Could we get it out today?
Don't cry like a baby.
Everything. Right, now, there goes his foot. Oh, my God. This is look like the Atlanta railway station on Gone with the Wind. This is getting me a major problem. Let's go and see what's going on. Yeah, here. Right. But you turn up in the morning and it looks like a mob scene and something out of Gandhi, right? And you think, how are we going to get through all this work? What on earth is going on? And so it's quite a deal. So this little fellow had an infection in the bone of in the bottom of his leg.
The daily rounds at the Children's Surgical Center in Phnom Penh.
Is it any better? Does he feel better now? But it's about a 4-month-old baby, so she's...
Its founder, Dr. Jim Laurie.
Right, okay, yeah.
In impoverished Cambodia, surgical treatment for most people is unattainable. Traveling from every part of the country. If they can reach this treatment center, they have a chance of an operation, a new start, a new life.
It was obviously corrosive in some way. It wasn't a normal injection. And on this side, she can bend a knee, but a kneecap, instead of being over here, is over here. There's a kneecap. And it should be sitting on here. Right? So there's
in bed after bed, a challenging range of surgical cases. This is a nation still trying to rebuild a medical system a generation after the murderous rule of the Khmer Rouge.
She couldn't bend at all. She had it like that. She couldn't bend it. And that's obviously a big problem in a country like this where you squat to go to the toilet.
Cases that often have gone untreated for months or even years.
So we're pretty happy with all this. We're doing neglected disease, really, that nobody's really done it. And that's basically what you're going to see all around here. Yeah. I normally count up to 25-year-olds as being kids, and a lot of these people have diseases that they got as kids, right, that are still bothering them now years later. But the basic problem is that we're offering free surgery, and if somebody comes around and is too poor to pay for it anywhere else, we'll sort of do it for them, no matter what their age. That looks good. Yeah. He had his hip dislocated for about 3 years before he came here. Fellow, how did he do it? Did he fall off a tree or what?
Playing football.
Yeah, he's playing football, dislocated his hip. And it was about, I think his was 3 years. We have another little boy that we just did. It was 5 years dislocated, the one that we just done this morning.
What kind of condition do you live in if you had a dislocated hip for 5 years? I mean,
well, you know, you've got a very shortened leg, and you're limping around, standing on your toes, sort of like this, right? And that's what he did for 5 years, right? Right. So I don't know why it took him 5 years to get here, but it did.
And I describe to a lot of people when they ask me about my father, I say he's the kind of person that loves to get up every morning, just simply bang his head against a concrete wall until he falls over at the end of the night, goes to sleep, and gets up and does it again the next day.
Now the skin graft is healed. It looks really good.
Now I used to him. I know that it's good-hearted.
There's going to be 3 ENT surgeons and an eye surgeon.
Dr. Jim Laurie, an Englishman with Irish roots, studied medicine at Trinity College, Dublin, and then began roaming the world. After Australia and South Africa, he came to the U.S., where he became an orthopedic surgeon in Alaska. That's where he may still have been today, had it not been for the chance of a quick relief mission to Cambodia. A quick mission that has turned into almost a 20-year commitment.
What happened was that I came here in 1992-93 with the American Red Cross for 6 months, and really thought that this was the most destitute place I'd ever seen. And a couple of years later, some of the people who I'd met at that time asked me to come back and set up an organization for landmine victims who'd had the landmine in their hand when it went off. So the people putting it down or picking it up, or sometimes just kids picking it up. So we came back in 1998 and started to do that. But I knew from my time before that there was a huge dearth of surgery and there are a lot of crippled kids around. And so I came back with the idea that we'd start the program for landmine injuries, but we'd do whatever we could when we came along. And then as soon as we started, the polio kids came in and everybody came in, so we ended up really doing whatever showed up.
On the operating table this afternoon, a young man, Nong Sak Na. Like so many, he has a condition that has gone untreated for years, now requiring major surgery.
What we're just going to do is a boy with some great big tumors on the back of his shoulder. They're bony tumors, and they interfere with the function of his shoulder, and he looks terrible, so he wants us to take them off. The problem is they're very big, and the access to them is going to be difficult, and so it's going to be a bit of a difficult operation. It's certainly not something that we do commonly, a big one like this. And he's got them on his scapula and on the back of his humerus, and I'm anticipating a little bit of trouble. You can't. You're going to get bag the nerve somehow, right? Yeah, I think that we're going to have to reflect it here. So I think the deltoid is...
In a country of such primitive medical resources, as news of the center has spread, it has found itself dealing with more and more complicated cases from people with nowhere else to go.
To make, right? I mean, you know, basically the deal is here, you can't just wait for another specialist to come along because you're the specialist, right? It's a big problem, right? No, it's a big problem, right? Okay, let's stop the bleeding as we, all right, go on, going right down through the fat, right down to the muscle. Yeah. We didn't have general anesthesia at first, right? So we had to start off with things that you could only do under local anesthesia, and then as we got more staff and we got more skilled, things started building, and then we've learned to do more and more. And so as time goes on, we're getting into a little bit of a problem that we're becoming a sort of tertiary referral center for Cambodia instead of doing the sort of bread and butter stuff that we started off doing. Right, and that has a little bit of a conflict in it as to shall we do that, shall we not? But if we don't do it, nobody else is going to do. Yeah. Oh, hang on. Yeah, it's no good to explain all this to me over the phone. My idea might be different from yours. If you want us to see him, send him down. We'll see him. Well, I doubt it. It sounds like they've done the right thing. From what you're describing, they've cut off a piece of board and closed the flaps over the ends of the fingers. So that sounds okay to me. That's what we would do. No. You can talk to one of my Khmer staff. I'm sorry, I'm in the middle of an operation. I really can't, have a... No problem. Yeah, let me just put one of my Khmer staff on and they'll talk to you. Okay. Now, you're getting into the bottom, that's teres minors and teres major. You don't... If you're going to divide... No, you should be really dividing this down here so that you can strip it forward if you need to. Right, but there it is.
Assisting in the operation, one of the Khmer surgeons employed at the center, Dr. Sun Rata.
Stuff going free. Right, okay, yeah. Well, there's a big nerve that comes out here that gets the big muscle, your deltoid muscle, that makes your deltoid muscle work. And if we cut that nerve, and the nerve's somewhere in this tumor, got to be somewhere, but the tumor's distorted everything so much that we don't know where it is. Is that it? Did you just fry it? Yeah, you did. Yeah, no, that's a nerve, I think. But it's not a very big one, so... I mean, it's a challenge every day, right, to decide, are you doing the right thing? Should we do this patient? What should we do? And I think that it's a bit wearing. You need a break now and again. And, and then you just got to wing it and have a go. Right, what do you want to do? Tell me. You've got to tell us, right? You can't just as guessing all the time, right? You should, as I said before this morning, you've got to talk to us, right?
The aim is for the local team eventually to become proficient in the kind of surgery Cambodia needs.
Top of it, so you're going to need incise up here, right? Right, and then, yeah, but which muscle is it, number one? Which muscle is it, right? What do you think it is? No, I don't think it is, right? It might be infraspinatus. Okay, so infraspinatus, if this is the... So there's the spine. Yeah, it's infraspinatus. So you can free it a bit more along this edge. I think, look, we've got to start chiseling it off, right? He's obviously had it since birth. And we don't know how long it's been since he really started getting bigger. Okay, give me that one. Right. Okay, I'll start at this end, and then you can start at that end. I hope his blood doesn't bleed like hell somewhere.
Working from both directions with chisels, eventually the largest of the tumors comes free.
Take it, give it to him. Okay, let's take the rest of this. Big swab, here.
It's a boy.
It's a boy, yes. Right over there. This is the tumors that came out of his back. There's bits and pieces as well. The problem is, if this is a sarcoma, which I think there's a possibility that it is, and this is not good for him. Now, give me the bone cutters and the bone biters. There are 3 tables in this one operating room, right?
And can they all be working at the same time sometimes?
And most of the time they are all working at the same time. It's just lunchtime now. What we've tried to do is keep this as a Khmer operation. So we've got about 16 doctors on the staff, and the idea would be that we are training them all the time to get better, do better surgery, be more accurate diagnosticians, decide the right things, how to do it, and they provide the vast majority of the care. So if you could explain to him, right, so he can learn, that would be great. Yeah? Is that okay with you?
Yes.
You know, so if you could work with Dr. Rata, right?
Yes.
He speaks English a little better than Dr. Money, and he talks a bit more. So it'd be easier for you to learn, right?
Yes.
Okay, Rata? Yeah, all right. Then they get training either from me, who's here all the time, or the foreigners who come in and who visit, and they will give you 2 weeks of their time and effort and show you how to do some things, and then gradually the Khmers learn to do it, and then it becomes available in Khmer society without the foreigners. Oh, it's been an extraordinary change here in Cambodia. Yes, absolutely extraordinary. I mean, the way that when I came, there were no working traffic lights. There were some white Land Cruisers belonging to the UN, and apart from that, a few little old Russian vehicles, and then everybody was walking, or at the most had a bicycle.
Just as Cambodia has developed, the medical services available here are undergoing dramatic change.
Block. Okay, yeah. Okay, I couldn't.
On this day, Goligly goes to a modern cardiology center to check up on the progress of a young patient. Until a few years ago, such facilities were unheard of in a country whose medical system was shattered during the decades of civil war.
Okay, you get a picture of
When Goligly first arrived, the medicine he found being practiced came straight out of the history books.
Right, but to have a center like this where they can do open heart operations, and it looks as clean as it does, and everything looks good, that's a real achievement here. You know, 1992, that was incomprehensible. I mean, the surgery was sort of like about the time of the American Civil War, when you got your leg cut off if you had an open fracture of the tibia. That's what was happening here. But since that time, I mean, you know, it's now 16 years on, it's sort of moved forward to sort of time at more or less the end of the Second World War. From the Civil War to the Second World War, they've done in 10, 15 years what took about 100 years in America, right, as they moved on.
In rebuilding the system, expertise from overseas plays a vital role.
Scan le tissue pour faire l'anapath.
Goligly is on his way back to the operating room, taking with him a visiting colleague from France. The case that awaits them is particularly harrowing, even by Cambodian standards. Nick Lom is a farm worker who was lucky to be alive.
So today we have here Dr. Philippe Michaud, Professor Philippe Michaud from the University of Toulouse, who comes to Cambodia twice a year, and he's a plastic surgeon, burn surgeon, so he's very experienced, so he has been helping us with this lady since we started. So this is a lady who's only 26, who 2 years ago had a fight with some sort of rice threshing machine, and she came off the worst. So she went to the hospital where they fixed up her arms and her legs, the wounds on her arms and legs, and did a little bit to her head, but the machine tore off all her hair and her scalp, and she lost her right eye. And so she's been in the village in this circumstance for about 2 years with no cover, no skin on her head. And she was seen there by an NGO who looked at her and said, this lady looks terrible, and called us up and asked us if we could do something. So we said, yes, bring her in and let's have a look. And we're gradually dressing these wounds of the head, trying to feed her up so she'll heal something, and then we'll do a skin graft. Now, it may take us a week or two before we can do the skin graft and before we get this all off, but if we hadn't done that, she almost certainly would have died. Okay, just go slowly, guys. Start taking it off here. Yeah, no, right, because she was gradually getting weaker and weaker and losing fluid and protein from this. Blood and pus, yes I know. Okay, well, just go slowly, you know. What do you want us to do? So as you can see, it's a pretty terrible injury, and it's infected, and there's parts of bare bone showing. And okay, Philippe, je vais enlever la tête. Is it prêt? Okay, attends. We've been working on it now for not quite 2 weeks, and it's a lot better than it was when it came in. I mean, this is getting dressed without any anesthesia or anything in the village for 2 years, right? I mean, you know, by whoever's doing it there. They've done a reasonably good job to keep her alive this long, right? Not being too bad. Now, are we just going to cover this, Philippe? Vous voulez seulement couvrir cela et laisser comme ça? Oui, mais c'est mieux, je ne sais pas. Okay, we've got some more flamazine, Yina? What we're putting on is flamazine, which is silver sulfadiazine, okay? It sort of has an antibacterial ointment. No, let me just do this one. Okay. Very good, Suckling. I know it's hard work, right? I know it's hard work, right? Very good. Where do you want another one, Philippe? Yeah, all right.
Il faut coucher sur le ventre.
Yeah, okay. On va charger
Coucher
ça.
sur le ventre.
Right.
Sinon, jamais.
Okay. Sopos, Tom? Listen, she's laying on her back too much, like that. Eh? Can you undo, Philippe? Call them again, tell them that she's coming, and make sure they get all the medicines, right? Cimetidine, iron, vitamins, right? The whole thing, right? And the food. Okay. Adai. Oh, okay. Chew tick tick. Oh, good.
Now, a day after his operation, Nong Sak Na is recovering well, getting used to life without the huge tumors on his shoulder that he grew up with.
So it looks like so we did this guy yesterday, and he's doing okay. He doesn't have very much pain as long as we don't move his shoulder. But I'm a little concerned still about the nerve function. He says he can feel, so that's good, but he doesn't feel the same as on the other side, so we may have stretched that nerve, whatever we did. We've got away without any major damage, and then we've removed his big tumors, and he's got some sensation, so it looks good. Right.
Hearing about the center, normally by word of mouth, patients travel to Phnom Penh from all parts of Cambodia, often with horrific ailments, in search of a cure. For some, it's too late. By the time 5-year-old Chakriya arrived here, her condition was inoperable.
Large tumor on her face, which is a sarcoma, and we first saw her about 6 months ago, and she's been with us since that time. So the plan was to give her chemotherapy and then transfer her to the University of Hong Kong for treatment. And so we started the chemotherapy here, but in spite of the chemotherapy, the tumor has grown. And it's so big that the surgeons in Hong Kong say that they cannot operate on it no matter what. And surgery would take away all her face and stuff. And so it's a sort of, we can't see a way out of it. And now can doctors in Hong Kong. So we're essentially trying to keep Chakriya happy, really let nature take its course.
Right.
Yeah.
How do you handle cases like this?
Well, it's very difficult. Grit your teeth and keep going. Yeah. So Chakriya is just sitting here.
Chakriya spends her days in the seclusion of a quiet suburban house that is also home to victims of acid burn attacks. It's a widespread social problem in Cambodia. Acid is often used to settle domestic feuds. In caring for the survivors and giving them work with rehabilitation programs, Goligli is helped by his wife, Kanya Rienvik, a Thai accountant whom he married after starting up the center.
Oh, well, basically, Kanya's my wife. She came along, started working for us as a volunteer. I was divorced. I subsequently married her.
It is the typical story, Rob. This is the guy that went into the government hospital and then pay as much as he could and then spend all the money. And then right now, no money. The hospital doesn't want to keep them, so kick them out. You go wherever.
Kanya has a particularly important job this day, comforting 20-year-old Long Pros, about to undergo an operation to implant an artificial eye. Long Pros is a victim of sexual slavery who was disfigured by her pimp.
This is the girl over there. She's sitting there, and then this is the collection of our artificial eyes that we are going to put on her today by our Khmer doctor. And I picked the color because we have many colors.
When the other thing comes, you've got a servo coming through.
And then I picked these two. Look similar as her eye color that we're going to try to put on her eyes today.
You know, this is going to be, I think that you might need a bit more filler or something. You might need a better eye, right? This is the standard artificial eye. You may need to have one of the visiting eye guys from America or something. Get a made-to-match eye, right? Right, because you've still got quite a bit of defect up here. But this will typically be, to me, 2 or 3 operations to get it right, to get the best result.
She's sort of a little bit scary, but she wants to do it. She doesn't think anything too much right now. She just focused on her surgery. She said that she likes to look normal, let's say. Don't cry like a baby.
Performing the operation will be Dr. Sun Son Ru.
It looks a lot better. Yeah, it looks a lot better. When we put the artificial eye in there. Yeah.
She wants to go back to live with her parents in Prey province, and then she wants to do sewing. Because Somali, my friend, she sent her to sewing class, and then she wants to have simple life. She doesn't want to see a lot of people. That's what she wants to do. She's just 20 years old, you see. She's been in bottle for a long time. Can you imagine how old she was there?
This girl was kidnapped as a child and then sold into sexual slavery and worked as a prostitute for about 7 years. And then one day her pimp stuck her in the eye with an iron spike and infected all her eye. That was in 2006. And she was still made to work after that. But about a month later, it was all pussed out and nobody wanted her. So she was then thrown out of the brothel, went to another eye hospital, Takeo Eye Hospital, where they took the eye out and treated her for the infection. They didn't have artificial eyes, and they don't do reconstructions too much, so they sent her here. So we operated on her in October and put a false eye in, but the socket was so deficient and there was so much space that the eye fell back too far. So in December, we put in a graft from her scalp. It's gone into the back of the eye to fill up the orbit. And now we put the eye in again and are trying to make it look a lot better. So it will look better after this, but we'll probably have to do it once or twice more to get a really good result, right? We'll have to trim it a bit, let the tissue shrink a bit, see what happens, and get it all done. So it'll be 6 to 9 months before we've really finished. And by that time, she should look pretty good. The eye won't move, but it'll be the same color as the other side, and it'll look normal when she looks straight ahead.
Evening at home in the Goligly house. Kanya and Jim watch their daughter Uma's first steps.
You're going to walk to Daddy?
Yeah.
Can you walk to Daddy? Oh, no, not too fast. No. Just go there, stand there near Mommy. Okay, it's okay.
Back at the surgical center is Goligly's son from a previous marriage. Sorhab is also an orthopedic surgeon. He takes a break from his private practice in Monterey, California each year to help with his father's mission.
You fixed her meningoencephalocele.
Yeah.
Sorhab basically went to school in the States, having been born in England, and is an orthopedic surgeon and specializes in spines and hip replacements, redo hips as they call it in the business, and works in Monterey, California, and comes over here once a year. It's all just necrotic and gone.
You couldn't find two different practices than my practice back home and private practice in Monterey, California, my experience of coming to Cambodia. Back home, I see patients in clinic 3 days a week. I operate 2 days a week. I operate in the crown jewel of hospitals in California, which is an absolutely beautiful, couple $100 million facility with views over the ocean and from our operating rooms. It's clean, it's white, it's sterile. There are very, very nice cars in the garage, and people have extraordinarily high expectations. Here it's completely different. We're operating with operations going on at the same time in an operating room. All of the equipment here is kludged together. It's begged, borrowed, and stolen from various different sources all around the world. And the patients that we see come here from all over Cambodia, largely by word of mouth, with some of the most horrendous diseases that you can imagine. I always tell people that the greatest thing about going to Cambodia is the first thing that you can get out of your medical vocabulary is the question, what brings you to the doctor's office today? Because if it's not readily apparent by the time it walks in the clinic, it's rare that it's something that we're going to treat over here. And then the other thing is that as you've noticed by being here, you can see some of the most horrendous aspects of disease here in Cambodia. I mean, sometimes clinic at Children's Surgical Center is a little bit like the bar scene in the Star Wars movie. I mean, there are things that you just simply don't typically see. And so I really enjoy coming every year. It's a difficult trip. I always go home pretty worn out and exhausted. It's emotionally challenging, and the surgery itself is very, very difficult here. But it's been rewarding to see the progression of skills in the institution over time.
In the consulting room, their collective expertise is needed in the case of 9-year-old Mun Shan Visna.
Where's he been getting treated? Who's been giving him the braces?
He was born with severe deformities of both feet and one hand. The team must weigh up their options.
Okay, this hand is good. Does he go to school?
Yeah, he's
Yeah, Tanakti man.
Maybe I'll get something out of that, huh?
Yeah, I think you can do that. But, let's leave that for the hand guys.
Yeah.
Right, we'll find a hand guy for that. Let's do these things. We'll never get a foot guy. Right, we've got to do this ourselves. Show us your hand, Twinny. Right, okay. Okay.
Given the challenge of operating on such rare deformities, the boy's case is the kind that attracts interest from overseas specialists.
Okay. He's got two, right, metatarsals, and the toe is bifid.
Details of his deformities are compiled in the hope an overseas hospital will take on his case.
Bring this down under here. Okay, Molly, we'll let you know.
Yes.
Right?
Sorhab Goligli's specialization is spinal surgery, and several cases have been awaiting his visit. Among them is Tung Navi, a 13-year-old girl suffering from scoliosis, or curvature of the spine.
3 spines. 3 new spines. Where are they? 3 new spines? Yeah. Right. Okay, come on in.
Yeah, so this is a 13-year-old girl with scoliosis. Looks like she's got a little hemivertebra here.
1996.
Measuring the curve with a technique called the Cobb method, and then she also has this really bad curve like this.
13-year-old female, 42 degrees scoliosis.
You ready?
Yeah, go ahead. So, you want to put her down? She's 13 with not a terrible deformity.
Yeah.
With trying to straighten out the thoracolumbar junction.
Yeah.
It's probably going to get you 50% of the way there with 20% of the morbidity of doing it anteriorly and taking down the diaphragm.
You want to do it this afternoon?
Yeah.
Okay.
Assisting in the operation will be Dr. U Chung Niep, the most senior of the center's Cambodian surgeons.
They are afraid that the condition may get worse and worse because now since 2 years she got that it changed a lot. When she goes to school, usually she's teased by her friend about her spine that's abnormal, it's curved. So that now she wants to have her spine straight like the other kid. That's why she wanted to have the operation.
So Niep is more or less my right hand. I would say he's one of the best surgeons I've ever met in my life. Not just Cambodia, ever. A guy who can come up, look at the new problem, is willing to take it on, learns how to deal with it, and can think straight within the parameters of that problem.
But Dr. Niep wasn't always going to be a doctor. He wanted to be an engineer, but the Khmer Rouge changed all that.
What made you want to be a doctor?
I think at the time it was my father's death during the Khmer Rouge. I had wanted to be an engineer, but then I switched to be a medical doctor.
Just outside Phnom Penh, Cambodia's notorious killing fields, the site where thousands of victims of the Khmer Rouge lost their lives. Across Cambodia, it's estimated the genocide cost 2 million lives. Anyone considered part of the educated elite were especially at risk, including the country's doctors.
I think before the Khmer Rouge, we have several hundred doctors. And then when the Khmer Rouge came to power, then all the doctors, all the officers, everybody had to leave the town to go to work on the rice field and so on. And there some, or most of them get killed or were starved to death, something like that, got a lot of torture. Then after the Khmer Rouge, I think only very few doctors come back alive.
The one I saw you yesterday with, and I said...
Still trying to rebuild the medical system, Cambodia remains heavily dependent on foreign help. But Dr. Niep knows that one day they must become self-reliant.
Please write on the chart every time you see someone. Can you see it?
I fully agree with the idea that the Cambodian doctor must not rely too much on the foreign doctors, because this is Cambodian, this is our country, so we should build our country by ourselves. Sure that the foreign doctor will come to help because we are in lack of some knowledge, of some technology, of some skill, and so on. But we have to profit to learn from the foreign doctor so that later on we can do everything by ourselves.
So if you figured out that it's...
With that foreign help comes something of a culture clash, especially in the form of Dr. Jim Goligly.
Possibility or not? Why don't you just say to me, okay, we thought about that, it ain't going to work.
Hailing from an old-school medical tradition, his abrasive style is sometimes at odds with a younger generation, and often at odds with the softly spoken ways of the Cambodians.
See that kid? Yeah, we need to find out what's wrong with that kid. Right. What's the matter with him? Do you know?
Broken leg.
A broken leg? Well, it didn't wait for Dr. Niep. Bring him in now. Let me have a look at the x-ray. Has he got an x-ray?
I look at my dad and I have an incredible amount of admiration for him.
Broken leg?
Where's your skull shot?
I think that there are few people that could accomplish this, and I think that there are undeniable personality traits that some people would call dictatorial, some people would call bulldozer-like, that allow someone to come to a country like this and build a hospital up to the point where it does 4,000 operations a year.
So Clay, cut it out. I did this whole operation without an IV. I don't want an IV now. Oh, immigrant. Why can't you stick it in the groin? Huh? I mean, it's just awful. I mean, you can basically take some blood right here. There's no problem, right? Okay.
And it's hilarious, as you've seen. I mean, you would think that this hospital has been in operation for 10 years, and watching him communicate with the staff, you would think this is the first time that they've done this stuff, with the amount of yelling and shouting that goes on. So it's not my style, but I can't deny its effectiveness when you look at what the project's accomplished.
Here's the artery, right? No, you don't just do that, Suckling. You find the artery, and then you're going to take it down here. You see how dirty it all is? So just rub it here, very hard, right? So that you're cleaning here. Then you put the needle in there. Feel the artery? Do it. I'm sort of, whether I'm an explosive Irishman or whatever. No, if I say things nice and quietly, they don't always react. They don't always quite understand, and they don't understand it's a request or an order or anything like that.
Also, there's a generational thing. As medicine has evolved, It used to be very common for people in the first world to have personalities like my dad. There used to be a lot more screaming and shouting. There used to be a lot more thrown instruments in the operating room. It used to be acceptable to kind of lose your temper. And now, of course, that's not the case anymore. I mean, we live in an environment where we're really good at what we do. We basically are following a flight plan. The expectation is that we're calm and polite to everybody, and if not, we end up probably in some sexual harassment committee somewhere explaining our behavior to somebody else.
So Kling, you need to be able to manipulate the syringe. So you've got to have your fingers up here like that. Have you done this before?
Yeah, I done.
How many times? Once?
Many times.
Many times. Well, it doesn't look like it, right? It doesn't look like it to me, right?
Me, when I started to know him, it became to me very strange when he shout, when he scream. But now I used to him, I know that he's kind man.
Your fingers out. You take this finger off now. You don't need these fingers. You don't need these fingers now. In Cambodia, because of the language problem, they're paying attention more to the tone than to what the words are. Very good, Sokling, very good. Good. Got a name on and everything? Yeah. So I've got to change the tone depending on what I want done. And if I want something done, and I just say it nice and calmly, can we transfer this patient over there and let me know when it's done? It's just a conversation. They're not paying very much attention. But if I say, now transfer that patient over there and call me when it's finished, then it's far more likely to get done. And then I'll be less frustrated.
Very curved scene from the front of the spine.
So Rob is quiet and very friendly. He will not shout, he's more patient. But Jim is, this is a bit of difference between the father and the son.
It is with the son that Dr. Nep will be working as Teng Navi is prepared for her back operation.
So the way this will work is Niap will do it. I do one half and then Niap does the other half. And in the process, get the operation done. So we'll give her a general anesthetic. She'll lie face down on the operating room table. It'll be a large incision. And then we're using older generation spinal instrumentation here. We have kind of a hodgepodge of different forms of instrumentation that have been available to us that we've scavenged over the years from various different hospitals and donations. And so we'll hook that up with two stainless steel instrumentation rods and place something that we call sublaminar wires underneath a portion of the spine and try to correct the spine as much as possible given the limits of the instrumentation that we have, and also the fact that this isn't really the most ideal setting in the world to do really, really aggressive correction. And if this was done back home in the United States, we'd have a neurologist monitoring spinal cord function. And the thing that we worry the most about is someone who has a cosmetic deformity of the spine that we know that's going to get worse over many years, has a spinal operation and wakes up paraplegic. So this is an example of how rare this case would be in the United States. Over a 25-year period, I think there may be 15 or 20 cases. I don't know that it's any more prevalent than it is in the United States. It's just that this is the only institution in the entire country of 12 million people that's at least going to look at these and do it. So every time I come here, I'm always amazed by the frequency of really severe spinal cases. On the other hand, the vast majority of what I do back home in the United States is back pain, and we don't see that here. I'm sure they have back pain in Cambodia, but it doesn't come to the clinic.
Okay, so we're trying to organize this operation, and the basic deal is we may not need a blood transfusion, but we may. And we don't want to run into problems where we have no blood if we really need it. We've sent the patient with our laboratory technician over to the blood bank, and the patient and her father went over there. And normally they want, for every unit they're going to give you, they want a donation of a unit. So her father has gone over there and donated a unit of blood, and we now have 1 unit of blood, right? But we want 2, right? So their story, the blood bank story is, maybe they can give us another one at 5 o'clock. Well, that may actually be not too bad for us, but we'd like it before that. So what will probably happen is if I've got a minute, I'll run over this afternoon and give a unit of blood, and then we'll have the 2 units. It won't be a problem.
Okay. Mine's not working.
And the big difficulty is having the blood when you need it, not waiting till 5 o'clock or waiting till whatever. If I go and I give them a unit now, we'll be 1 unit up. We might be able to get 3 for this lady if we need it. But we're sure to need it tomorrow or the day after, right? So usually what I do is when we have some big surgery like this, I get all the foreigners to go and give some blood so that we're sort of ahead of the game. And then if we need one urgently, the blood bank will maybe give it to us. It's a sort of little game we play.
Can you open the tray of all the spinal stuff?
It's the usual problem, right? There's nobody in the blood. This is where you donate blood, there's nobody there. It's all closed up, right? They've all gone, right?
You know, 1960s technology, but things are going fine. Actually, we're doing really well. So we're doing just fine.
What do you think I'm coming in for?
These are called Harrington rods. So these are the original rods that we use to treat scoliosis. And it's a medical grade stainless steel, and it's a really stiff alloy, and it's difficult to work with, and but it's here. When I do this operation at home with all the toys I have at home, I have titanium alloys, I have intraoperative x-ray, I have 1,000 things that make that technical operation so much easier in my hands at home. Here, typically the deformities are bigger, the patients are smaller, the instrumentation is clumsier. It's something that we were using in the United States 20 or 30 years ago, and the entire process is difficult.
After a promising start, they run into trouble.
You know, it's
One of the hooks needed to anchor the rod into position keeps coming free from the spine.
Did we break it?
Probably should have a better rod because we have a problem to fix the upper hook.
Can you still get underneath there?
Each time we try to put the rod in, and the rod just split out the bone.
Yeah. Grab the end of this one here.
Oh, thank you. Souvenir for me. You usually get a Coke and a sandwich, right? Let me show you. Yeah. What does it say? 1 donut to serve many people. Okay. That mean beer there. That mean beer.
The team now have the units of blood to complete the surgery, but the problem of anchoring the rod now puts the whole operation in doubt.
Oh, careful. It's useless using this stuff. It really is. It's way too stiff for a kid this size.
Yeah.
It's way too big. It's the wrong stuff.
Is it just the top hook that goes with the hole?
Yeah.
The hook fails to take again.
Okay. Well, the other alternative is that there won't hold, right, is that we fuse her and put her in a cast.
Yeah, I know that.
Yeah.
have much confidence that it's going to work until the last moment that we try to put the hook under.
They persevere, and finally the rod is secured in place. The operation is a success.
I always have heartburn in these cases until they actually wake up and wiggle their toes.
Great.
Well, Nia, what'd you think? Should stay at home and go surfing. The fact that we're using equipment that's older, the alloys are a lot stiffer. It's stainless steel rather than modern titanium. It's a big curve, and then it's a very, very, very small patient. I mean, she's 13, but she's probably the size of a 9-year-old back home. But everything went fine. I mean, we got the correction that we wanted, which is probably 40 or 50%, and instrumented and wired and straightened out. And so just make sure that everything's okay with her spinal cord.
Early morning in downtown Phnom Penh, and the working day has already begun for Dr. Nyep at his desk, quietly writing his thesis.
This is a thesis on meningoencephaloceal that I operated on Children's Surgical Center.
The condition is a meningoencephalocele. It's an outpouching of the lining of the brain, the fluid around the brain, and some brain itself coming through a hole in the skull and coming out through the forehead onto the face.
It's a birth defect thought to be produced by mothers eating moldy rice during pregnancy and found throughout Southeast Asia. Allowed to go untreated, it seems to be fatal, with no one yet surviving into adulthood. And Dr. Nyep has probably had more experience of operating on the condition than any other Cambodian doctor.
It's not in Cambodia, but all the whole Southeast Asia. It's very common. In Thailand, in Burma, in Malaysia, in Cambodia. We've done 162 cases already.
Yeah, Nyep's the world's expert on this condition.
Not quite. Right. Cambodian expert.
Cambodian expert.
So we think that this is found in rice farmers. It's sporadic. People grow rice, they store it. In the rainy season, the rice can get moldy. A mold produces a toxin that interferes with folic acid. If the mother is pregnant 6 to 8 weeks, when she eats the moldy rice and gets a dose of the toxin, it interferes with the baby closing off what's called the neural tube at the top end. So this is quite common.
Despite its prevalence, relatively little work has so far been done on it because it largely affects the poorer sections of the community.
Yeah, basically this is poor people out in the countryside, but in the towns, people would probably just be buying rice from the shop. The rice would not get moldy, otherwise people wouldn't buy it, so they don't get the condition.
It illustrates one of the inherent inequalities in the Cambodian system, where medical resources are often directed towards those sections of the society that have the ability to pay for them.
Oftentimes the people who would be the best physicians are not the people who are moving through the medical school system. Then once they get out, they need to be able to make a living. And oftentimes the people who can afford to pay are the people who have less and less wrong with them. And so what you see in a lot of these third world countries is that a lot of people who actually do have talent and are licensed by the government to practice medicine end up running rinky-dink family practice units where they see a lot of patients and they basically run a pharmacy and they provide a lot of pills for people. And so my understanding is that's very, very common here, that a lot of people will graduate from the medical school system here, and what they'll do is they'll go into private practice where essentially they're running a pharmacy. They'll see the worried well of Cambodia and they'll give them pills. And oftentimes they don't have the resources that surround them to be able to make use of their talents to become surgeons or to do particularly difficult things. Come on, buddy, you and me.
Thankfully, Dr. Nyep finds himself in the kind of environment where he can become the surgeon he aspires to be. Now an expert in meningoencephalocele, he is also becoming proficient in scoliosis.
Hold the big toe up towards your head.
Together with Sarhab Goligli, a look-in on their scoliosis patient, Navi.
Up that way.
Just one day after her surgery and getting ready to walk again, a lot straighter than she walked the day before.
And she can feel everything normally?
Another successful step along the road of transferring expertise from visiting Westerners to their Khmer counterparts.
You know, medical care in a country like this is challenging. I mean, it's hot and it's sweaty and the air conditioning doesn't work and things smell and people have horrible diseases. And these are really challenging things to treat even when you're first world trained. And I think they can be absolutely overwhelming when you're third world trained. Does she feel like standing up? And so when you come to a place like this, for me, it's the best and the most difficult cases of the year that I see here. For a Cambodian, they don't feel that. This is just more horrible stuff they've got to deal with on a daily basis. Okay, come on, sweetie, let's swing your legs over. And so sometimes you have to kind of catch yourself that the enthusiasm that I feel for coming here and the complexity of the cases may not be shared by the Cambodians that I'm working with, because they're surrounded by this disease and disability all the time, and what might make them really excited is someone who's actually a lot better that they can really feel like they can have a positive impact upon. She should be getting up twice a day.
Twice a day, yeah.
Yep.
Yeah.
It's so much better for her in terms of her pulmonary function and,
and
everything else.
Okay.
And obviously her pain control is good enough.
Mm-hmm. Yeah.
So,
Is that a good result?
yeah, terrific. Terrific. Oh, okay, good. Let's go take a look at the film. This is our preoperative film here, in which she had a 42-degree curve from T10 to L4 of scoliosis. That's now down to 20 degrees across the same levels. And preoperatively, she had 82 degrees of kyphosis across the thoracolumbar junction. Now she has 45 degrees of kyphosis across the thoracolumbar junction. So single Harrington rod with a hook above and a hook below and multiple sublaminar wires, and pretty substantially improved correction.
Nong Sok Na made a full recovery from his operation to remove his shoulder tumors, and he returned home.
After he'd been home and he came back and he took out the sutures and he was much happier and everything looked good. We saw him about a month later after that and he was still happy and everything was going great, and we haven't seen him since. We usually presume that means that everything's going very well, right? That he doesn't see the necessity to waste money to come back to see us.
Mek Long, who was injured in the rice threshing accident, also made a full recovery, but her story took a tragic turn.
She made a complete recovery as far as we were concerned. She stayed with us for 2 to 3 months until we had 95% of her scalp healed. She decided to go home before we'd completely finished up and got it all healed.
She returned to her home, but died unexpectedly from a stomach ailment, completely unrelated to her injuries.
It's one of the things that happens. You spend all this time looking after somebody and they go home and something else happens which is relatively minor and there's a death from it.
This morning,
Long Pros is still undergoing reconstructive surgery to give her a false eye and give her back her looks.
on the superior and inferior chronic.
5-year-old Chakriya lived on for a while in the quiet Phnom Penh suburb, but as the tumor grew, she gradually became weaker. She was still alive during this visit by donors, but was slowly losing more and more
She was
weight.
playing and she was on the bike just a month or two ago, but now she's not. She seems to sleep most of the time. So the tumor's getting bigger, it's getting eroded, it's going to bleed, she's going to do something, right, and then she's going to die, but there's not much we can do about it now. All right, Samnang, let's see the others, whoever's upstairs, right?
10 weeks after this visit, Chakriya died.
So they haven't signed on the dotted line that they're going to do it yet, but they've looked at his legs.
For 9-year-old Visna, the news was promising. The Hospital for Sick Children in Toronto had expressed an interest in taking on his case.
Oh, they'll have seen something like this, but only occasionally. You know, if you've been going for 30 years, that's who the sort of doctor he's going to be seeing, right? They've seen this in Africa or somewhere like that, but they don't get it every day in Toronto.
A few months after this checkup, he was on a plane to Canada, where he underwent a series of operations on his feet and hands. He's now back in Cambodia, living happily with his family. 2 months after her scoliosis operation, Teng Navi is returning to the center for a follow-up.
Here she is. Hello, Navi. I'm going out in it.
She's now able to lead a normal life in her home village.
Okay, she said that it's easy for lie down, and then also she got more.
And she's taller.
height,
Yeah. But what about the other kids in the village? Have they made any difference? Did they used to call her names before?
Anhមួយពួកម៉ាក់អ្នកនៅ Yeah, she's scared. She doesn't like to go out because
backlog's
back is very bad. But right now, she's looked a lot better. So she stopped scaring and then can go out and play with the
other kids.
Everybody.
As she returns to that new life, so Dr. Jim Goligly returns to his whiteboard and the cases coming up for tomorrow.
So you see there's 8 patients on, which is a bit much for a Friday. But we have to do those 2 babies first. There's a 7-month-old with a complete cleft lip on the left, and there's an 8-month-old with a unilateral cleft lip.